of topics that will come up for new BHCs, and with the integration just basically exploding, it kind of gets us to this idea of where is our professional identity? You know, a lot of times when you're looking at organization structures and there's an integrated behavioral health program that starts, they kind of get almost placed under the existing specialty behavioral health program that was there. And then they're taking folks and putting them into the primary care setting. So it's kind of like, hey, should I still attend those specialty behavioral health meetings? How relevant are they? And essentially it comes down to this. What is the professional identity? Not that there's one answer, but what can be some professional identities for a behavioral health provider from your perspective of working in primary care for several years?
Yeah, I think you said it well already, that there's probably not one answer to this for sure. I'll speak from my experience and what my mind says for this. You know, this has definitely evolved. I think when I first got into integrated care, I definitely saw myself as still a behavioral health provider, whatever that was. You know, as I started to get more integrated, that started to shift a little bit more. And I will say now, I really do look at myself as a primary care provider, not necessarily a behavioral health provider. And I think there are some pretty important differences.
I was going to ask, what might be some of those nuances for what makes, like, what does that mean behaviorally that you identify more as a primary care provider? What can I see you doing? You
know, I think there's some logistics things that we might be able to talk about, but I think it's more just the spirit of how I approach situations. That when I meet with patients, this expectation that I'm going to have continuity with them and throughout their lifetime. I think that's one of the biggest things that always comes up. That whereas a behavioral health provider, even in an integrated care setting, a lot of times we look at patients as like, we're going to see them only for like a period of time and then they go somewhere else. Or they are doing better, so we do, you know, a termination session or whatever that might be. My way I look at patients is that I'm never going to be terminating services with them. I will always give the opportunity and the expectation that I'm here.
Once again, like a primary care provider.
Like a primary care provider.
A family doc, where they are my family doc.
So my mind having this conversation always goes to almost like the 4 C's of primary care.
Which are...
is first contact, trying to see as many patients as you can and having access be our main kind of driving force. Comprehensive care, so seeing patients for a variety of different concerns, and really we're not turning anybody away. We're that first contact for anything and everything. Continuity of care, that this idea of we're going to see people from the time that they're born until the time that they're, you know, aging and maybe going into a situation like a nursing home, and even in nursing homes, we would still have that kind of continuity with them. And actually a nursing home is a good segue to the 4th C, which is coordination of care, that we take responsibility of that patient regardless if we're having them see another provider, see another specialist. We are still their primary care provider. So I think the way I look at my professional identity, I always ask myself, like, where does my identity fit within the 4 C's? And that gives me more clarity about how I work with patients, how I approach patients, and generally how I interact. That I am part of this primary care system and I am a primary care provider. I think logistically as well, you know, a lot of times we see, as you were saying, we see interesting structures of BHCs within like organizational charts. You know, sometimes they might funnel up, as you said, through the specialty behavioral health, that they have behavioral health services within that organization. Sometimes we see them funnel up through operations.
So it's kind of like a program.
Yes, an initiative almost. Yeah, that's what it's really. I've even seen it where it's funneled up through the nurse team, and I think it's an important thing, and it goes back to kind of advocating for ourselves as providers that we should funnel up through the primary care provider system. And if that's the chief medical officer, which, you know, is most likely going to be, that's who the BHC should funnel up through as well. I do think this shift to being a primary care provider at times can be jarring in a lot of ways. Because my mind says it goes against the way we were trained. And we're not trained to think like primary care.
Yeah, I think that it is a huge philosophical shift, but it's also a very grounding and orienting shift. And so I must say, when I do work with trainees, and I don't even know how many times I say, your litmus test is, do the primary care providers do it? And if the answer is yes, then you probably should too. And if the answer is no, you probably shouldn't. So, for example, do primary care providers give an after summary visit? If the answer is yes, you probably should too. Do the primary care patients schedule their own patients? Your litmus test. If the answer is no, then you probably shouldn't either.
And I think that's a big one as well, because that's, I think all those logistical kind of things, such as scheduling patients, calling patients back,
faxing,
all those different things, I think they play a part of your identity.